Okay, so we are going to discuss a new station, infective endocarditis. A 56-year-old man is in a HDU. He is a post-op day 3 following a lab coli. Day 1 post-op, he became unwell with a bile leak, is but this spontaneously settled 2 days later. Yesterday he was feeling much better, however, on the ward round today. He is tachycardic, complaining of fever and night sweats, and has noticed small red lesions in his fingernails. The nurse shows you recent blood test results showing that the WBC and CRP have increased since yesterday morning. His post-medical history includes constant pancreatitis, hypertension, rheumatic fever, and appendectomy. Looking back through the case notes, you notice that the anesthetist has documented a murmur in the pre-op anesthetic review. So, it is a famous triad in medicine that whenever there is a new onset of murmur with fever and raised WBC, this is most probably infective endocarditis. So, definition of endocarditis: inflammation at the endocardial surfaces of the heart, including heart walls, which is caused by certain microorganisms. So, types: infective, non-infective. So, infective is because of the pathogenic organism, for example, bacteria. Here, microbes colonize the heart walls and form fibril vegetation. The two types of infective endocarditis are acute and subacute. Diagnosis always is done through Duke's criteria. Non-bacterial thrombotic endocarditis, also known as marantic endocarditis. This variant characteristically occurs in the settings of cancers, adenocarcinoma. So, Liebman 6. Okay, so these are two non-infective, but Liebman 6, here they have written that it's because of the adenocarcinoma or cancer, but it's not like that. It is mostly related to this SLE, systemic lupus erythematosus. So Liebman 6 endocarditis because of the SLE, and non-bacterial thrombotic endocarditis, also known as marantic endocarditis. This variant characteristically occurs in cancers like adenocarcinoma. So here they have shown the different types of vegetation which occurs in infective endocarditis. So in infective endocarditis, the vegetations are large and spread to the sides and are destructive. In non-bacterial thrombotic endocarditis, they are small and non-destructive and lines just the occlusion lines of the walls. And in Liebman-Sake endocarditis, also the same, small and non-destructive, but they are on both sides of the walls. In rheumatic heart disease, they are also small, warty, inflammatory vegetation along the lines of the wall closure. So these are the different variants. So I will go through major forms of vegetative endocarditis. The acute rheumatic fever phase of rheumatic heart disease is marked by the appearance of small, warty, inflammatory vegetations along the lines of the wall closure. As the inflammation resolves, substantial scarring can result. Infective endocarditis is characterized by large, irregular, often destructive masses that can extend from wall leaflets into the adjacent structures, such as codi or myocardium. Non-bacterial thrombotic endocarditis typically manifests with small to medium-sized, bland, non-destructive vegetation at the line of the wall closure. Liebman-Sake endocarditis is characterized by small to medium-sized inflammatory vegetation that can be attached on either side of the wall leaflets. These heal with scarring. What is relevant in the post-medical history here? So, rheumatic fever. What is rheumatic fever? It is a systemic disease affecting the heart, joints, skin, and brain. Usually occurs in children. Peak incidence is between 5 to 15 years. It is still common in developing countries and increasing in the Red and the West. It occurs 2 to 3 weeks after an untreated group A beta hemolytic streptococcal pharyngeal infection due to a type 2 hypersensitivity reaction, antibody cross-reactivity. So this is basically the pathogenesis. This is because of the okay. So further, there is a question in this station that what is the pathogenesis of rheumatic fever? So remember this thing, that infection occurs due to group A beta hemolytic streptococci. So there will be body will produce antibodies against this against the proteins or the antigens of the bacteria, specifically the M protein. So these proteins cross react with the hot antigens and they cause endocarditis. Sorry, carditis or inflammation of the heart muscles as a whole. Plus, there is also uh, stimulation of the T cells, CD4 T cells against the bacteria. So these activated T cells produce cytokines, and these further activates the macrophages, and they will cause inflammation of the heart walls. All the heart wall pancreatitis will occur. So these two mechanisms, the mm, antibodies generation plus the T cells generation or activation against the hot walls because of the bacterial antigens. So this is basic pathogenesis. Are you concerned about the hot murmur that the anesthetic is detected in pre-op? Yes, this may suggest wall damage from previous rheumatic fever infection. Any wall damage will then predispose to further infection. The fact that this patient had a bile leak makes the risk of infection even higher. What are the possible sources of infection in this patient? Since he has undergone surgery, abdominal surgery, so there can be intra-abdominal sepsis, there can be wound infection, there can be pneumonia because he's in hospital acquired pneumonia, there can be UTI, there can be line infection because he will have IV lines for medications and fluids. There may be infective endocarditis, there may be wound infection. How do you diagnose rheumatic fever? So rheumatic fever is diagnosed according to modified Jones criteria. So what is Jones criteria? I will give you a very good mnemonic for this. So Jones criteria. So here you write Jones. This is O in the shape of heart for you people, and this is Jones. So this is joints involvement. Polyarthritis. Polyarthritis. This is major criteria basically. This is pancreatitis. This is subcutaneous nodules. This is um, erythema marginatum. This is Sydenham chorea. So this is your major criteria. So this is minor criteria. Fever greater than 38.1 degrees centigrade, raised ESR, CRP, arthralgia, heart block in ECG, previous episodes of rheumatic fever. So these five are the minor criteria. So they say that what is the protocol for the diagnosis? So either two major criteria, your diagnosis is confirmed, or one major criteria and two minor criteria. Then with the presence of with evidence of streptococcal infection, so this will diagnose rheumatic fever. Why rheumatic heart and wall replacement patients are more susceptible to infective endocarditis? So rheumatic heart and wall replacement. So blood usually flows smoothly over the walls. When these walls are damaged, such that in rheumatic heart disease, or when wall replacement is done, there will be an increased chance of bacterial colonization on damaged wall because there will be turbulent flow. There will be less space, so they will cause turbulent flow. There will be fibrosis. There will be thickening. There will be thrombosis. There will be sorry. So there will be high colonization of the bacteria on these walls. So that is why they are more susceptible to infective endocarditis. So pathophysiology of rheumatic heart disease, I have already explained this. Since when these two procedures, though these two things occurs, for example, antibody generation against the heart walls and stimulated T cells, which will further stimulate the macrophages, which are actually called the macrophages are called ESCOF bodies. The whole infection is called scarf bodies granulomatous. So these combining will cause the wall damage. Recurrent inflammation, progressive fibrosis, nerving and stiffening of the wall leaflets with commissure fusion, retraction of the leaflet edges, wall thickening, calcification leading to stenosis. They will stenose. Pathogenesis of infective endocarditis in bicuspid valve. Remember, aortic and pulmonic are tricuspid, like they have three cusps. Tricuspid valve has also three cusps. Mitral valve is the only valve which has two cusps. So there will be in two cusps the space or the opening will be small. In three cusps these will be large. So usually, most commonly, the infective endocarditis occurs or rheumatic disease affects the mitral valve. They cause the mitral valve stenosis because of these two cusps. So nerving of the valve. So the question is pathogens of infective endocarditis in bicuspid valve. Nerving of the valve, stasis of blood, increased chance of bacterial colonization, recurrent inflammation, fibrosis, and scarring of the valve later on. What are the what are the macroscopic gross findings of the heart valve with vegetation? So, in acute phase, valvular vegetation, which is called verrucae, along the lines of the closure, having little effect on the cardiac function. Chronic phase, commissure fibrosis, valve thickening, and calcification, shortened and fused cardiac tendency, fish mouth shape. So here you can see this is fish mouth shape. What are the microscopic findings? So, uh, scope bodies will occur. A form of granulomatous inflammation which consists of central zone of degenerating extracellular matrix infiltration by lymphocyte, plasma cell, and anti-scow cell. Anti-scow cells are activated macrophages, also termed as caterpillar cells, because due to or because they have wavy nuclear chromatin or outlines found in all the three layers of the heart: pericardium, myocardium, and endocardium. So this is basically the microscopic features of the rheumatic fever or rheumatic heart disease. What are the gross features of these scope bodies? So scope bodies, these are the scope bodies. These are the, you can say these are the granulomas in the heart. So they have these anti-scow cells, which are called caterpillar cells. You can see here. Okay, so they have, if you look closely on them, so they will be scope nodules, fibrinoid necrosis. And if they ask you microscopic features, so you can say microscopic appearance of a scope body. This is the same thing as we discussed. A scope body is which is a chronic uh, granulomatous inflammation, or it is granulomatous inflammation with central necrosis associated with circumscribed or surrounding lymphocytes, plasma cells, and activated macrophages, which are called as anti-scow cells or caterpillar cells because of the wavy chromatin. Why is bicuspid aortic valve susceptible to infective endocarditis? Because there is an increased risk of stenosis and stasis of blood. There will be small opening. If infective endocarditis occur in tricuspid valve of a young patient, what would you suspect? I will suspect intravenous drug abuse or these will be intravenous drug abusers. Investigation to identify vegetation, 2D echocardiography. What to look for 2D echo? So you will look for valvular regurgitation, a regurgitant jet greater than 1 centimeter in length and peak velocity greater than 2.5 meter per second. Leaflet prolapse, coaptation failure, thickening greater than 4 mm, reduced mobility, nodules, annular dilatation, caudal elongation or rupture, increased echogenicity of subvalvular apparatus, pericardial infusion, ventricular dilatation and dysfunction, almost always with significant regurgitation. Common organisms causing infective endocarditis: Viridin streptococci or streptococci, Coccolese negative staphylococcus, enterococci, Hessek group. You can say Hessek is Hessek group microorganism, oropharyngeal commensals. So H is Haemophilus species, A is aggregati pector species. C is Cardiobacterium hominis, Echinella corrodens. K is Kingella species. How will you diagnose infective endocarditis? So Duke's criteria. So uh, in the previous okay, so how will you diagnose this infective endocarditis? So 2 major criteria, 0 minor criteria. 1 major criteria and 3 minor criteria. 0 major criteria and 5 minor criteria. So what is major criteria? So major criteria is major blood culture criteria. At least 3 sets of blood culture samples from 3 different sites, at least 1 hour apart, should be drawn. 3 blood cultures, 3 different sites, at least 1 hour apart should be drawn. 2 blood cultures positive for microorganism typically found in patients with infective endocarditis, like the common organisms. 2 blood cultures should be positive for them. Persistent bacteremia from 2 blood cultures taken more than 12 hours apart. Positive serology for Coxiella burnotii or Bartonella and Chlamydial psittaci. So this is major criteria. Major echocardiographic criteria. So this is blood criteria. This will be echocardiographic criteria. Wall vegetation, myocardial abscess, new partial dehiscence of a prosthetic wall, and new valvular regurgitation. Wall vegetation, myocardial absence, and new partial dehiscence of a prosthetic wall, and new valvular regurgitation. Okay, so now minor criteria. Predisposing factors, heart wall prosthesis or intravenous drug abusers. So either the patient has heart wall prosthesis or he is intravenous drug abuser. Fever greater or equal of 38.1 degrees centigrade. So this should be predisposing factor. Fever should be this. And vascular phenomena, major arterial emboli, septic pulmonary infarcts, mycotic aneurysms, intracranial hemorrhage, conjunctival hemorrhage, and general lesions. Immunological phenomena, glomerulonephritis, ocular nodes, Roth spots, and rheumatoid factor. Microbiological evidence, positive blood culture but does not meet a major criterion, is noted above, are serological evidence of infective evidence with organism consistent with infective endocarditis. Echocardiographic findings consistent with endocarditis but do not meet a major criterion as noted above means that these will not be meet, but these will be, so they will be considered as minor criteria. Okay, so listen to this again and again, you will remember.